Do you want to know more about how you can eat for better health and longevity, and how your diet and lifestyle can play a part in chronic disease? Then you're in the right place. I'm Claire Day.
And I'm Daisy Lund, and we are both plant-based doctors with a passion for improving nutritional education. In this podcast, we will bring you all the latest medical evidence on how a plant-based diet can improve your health whilst being kinder to the planet and fairer to the animals that we share it with.
Twice a month, we bring you interviews from experts in the field with a focus on an important topic related to plant-based health, all while sharing recipes and food ideas.
So, welcome to In a Nutshell, the Plant-Based Health Professionals podcast.
Hi everyone, this is Shireen Kassam, founder and director of Plant-Based Health Professionals UK. I've got two bits of news to share with you. Firstly, that we've launched our new conferencing brand called Nutrition and Lifestyle Medicine Conference, and our first in-person conference will be on September 9th at King's College Hospital, so do head over to our website to book tickets. Secondly, we are working on a plant-based food healthcare campaign. This is called Plants First Healthcare, and we aim to normalise plant-based meals within every healthcare setting, including hospitals. We have an open letter where we need signatures from healthcare professionals, so please endorse the letter to help get our message out far and wide by heading over to our website, plantsfirsthealthcare.com. Thanks for listening.
Welcome everybody to episode 14 of In a Nutshell, which, Daisy, am I right in thinking this is the last episode of this second series?
It will be, Claire, indeed. Hello everyone, and hello Claire. I've missed you these last 2 weeks since you've been away.
Yeah, so I've been on holiday and you're about to go on holiday, aren't you?
Yep, so you've just been on a train holiday, haven't you? Which is what I'm about to do as well. So tell us a bit more about it.
Yeah, happy to. I took the ferry from Harwich over to the Hook of Holland, and that was to enable us to use the train basically to get all the way down to Italy. So visited a few friends and places that I hadn't been as well in Germany, and then made it all the way down to Como, and then went on to Bologna, and then took the train back via, where did we go on the way back? We went to a place called Freiburg, and then all the way back to Utrecht. So why did we do that? Well, I mean, I think it's a good time, isn't it, to highlight about how much better. I mean, no travel is great for the climate, but traveling by train is so much better for the climate than short haul flights, because I was looking this up and it's 151 grams of CO2 per kilometre travelled per passenger. If you take a short haul flight, if you compare that to taking a ferry, it's going to be about 7.5 times less. And then once you get onto the trains, well, the trains can be quite variable. And I think it's difficult to estimate how much you're saving with this, because the Eurostar is a really efficient train and it only produces 4 grams of CO2 per kilometre per person. Whereas the estimate for a more general train is about 29 grams per kilometre per person, but it's still 5 times less than that short haul flight. And I know that you're going to be taking trains in Germany as well. And if you're able to take these really fast trains, these ICE trains, they are all powered with renewable electricity.
Oh, brilliant. Yeah, I'm keen to try it this one time this summer, not flying, and just use the train travel as part of the adventure as well. I think you can see lots of places on the way, and yeah, so it's a slower method of travel, but it's definitely, as you say, more environmentally friendly, isn't it?
Yeah, I mean, I was absolutely blown away when we got right down to deep in Bavaria on the train, and I looked out the window and I saw, oh my gosh, just the width of the Rhine, which I don't think I've ever really sort of appreciated before, but the width of that river. And then there's like a Rhine waterfall where you literally think, oh my goodness, just imagine going too far in your boat towards that. It really, I'm sure it's not anything like the Niagara Falls, but it looks pretty impressive.
Oh, lovely. So you got some scenery along the way.
Mm.
What was the plant-based food like in Germany?
Well, I think that Germany is now actually very vegan friendly. The only downside is if you go into a supermarket, you will have to deal with the meat alternatives being very sort of purposely placed above or next to the meat in the supermarket. But I did read that this was part of Germans wanting to reduce their overall meat consumption. So you'll have people who haven't decided to become fully plant-based, but they're consciously trying to pick an alternative. So it might be why it's marketed in this way. And on this note, of course, we've had new German dietary guidelines out, and they focus on what's best for individual health and also what would help best meet sustainability targets. So particularly in this way, the 2030 climate change targets. And those guidelines are recommending a minimum of 75% plants in the diet, and also consciously sort of saying you should be having a portion less of milk or milk products. And rather than allowing this 300 to 600 grams of meat a week, they're taking it down to 300 grams of meat in a week. But obviously, with the emphasis on eating as much plant-based food as possible.
Yeah, I saw that. That's good. That was really good.
And the other thing is that they used to kind of just describe it as a vegetable category and a fruit category, but they've taken out legumes specifically and put them in their own category, and nuts as well being emphasized, and actually consciously telling people to eat portions of those and amounts of those on a daily basis.
It's really good to see that have their own category now, highlighting the impact on health.
I mean, it's interesting how they're saying to have a minimum of 75% plant-based diet, but they still seem to be quite stuck on the 5 portions of fruit and veg. And I'm not sure how easy it is to achieve 75% plants if you're only eating 5 portions of fruit and veg in a day.
Yeah, I wonder why.
Well, I think it probably comes out the same as the UK's Eat Well guideline, isn't it? Is that, when people are so under eating on things, you've got to say something realistic or people don't try at all.
Yeah. So did you get your 5 fruit and veg a day on your holiday?
No problem for me. I was walking around with bags. I went in and specifically bought a bag of walnuts and dried apricots
Yay.
so that we could snack on those. And fruit was really easy to get hold of, obviously. But a few highlights were that Frankfurt, where I actually worked as an au pair many years ago. And, I blame Frankfurt for killing off my attempt at veganism at that time. But Frankfurt actually had its own vegan hotel chain and 2 restaurants associated with that, one of which is a Michelin-starred restaurant. So if you are thinking of going to Frankfurt, you do need to book that restaurant in advance. We didn't manage to go to it because we hadn't thought ahead, but there are those opportunities out there.
Oh, that's brilliant. It really shows that things are changing. There's definitely a shift, isn't there? And Italy, how was that?
So Como was a bit more challenging. I felt in Como I was staying with friends, so I was going to the supermarket and I found that milk was added to way more products than in the UK. In the UK, you'll often find soya in biscuits, but it's almost like there's a policy there to put milk or dried milk powder in almost every biscuit or bread that you can find. I mean, not the sort of normal bakery breads, but a lot of the sort of supermarket focaccias and things like that had milk added. And I wanted to make my own tiramisu as part of a meal we were doing, and it was particularly challenging to find the right biscuits. So I ended up using Biscoff biscuits that they had, which of course are a plant-based option. We got down to Bologna. There seemed to be more tourist restaurants, so there are more vegan restaurants, and we were lucky enough to have lunch at the Botanica Lab in Bologna, which was the winner of Italy's Best Vegan Restaurant Award.
Oh, very nice.
So, I mean, I did say I ate lots of fruit and veg on holiday, but I don't think you ever have quite as whole food, a plant-based diet as you do when you're at home.
It's true. Yeah.
And so today I had the last of the croissants that I brought back from Utrecht, because I was so happy that we finally got to have a decent pastel de nata, which I got at a vegan cafe called Life's a Peach. And it's a little walk from the station, but if you ever find yourself in transit there, it's a nice little place to pop down to, very calm, and they do some really lovely pastel de nata.
Oh, lovely. Claire, thanks for sharing tips and bits on your holiday. That was really nice to hear about.
Pleasure.
So this week, listeners, we have a really special guest and a fascinating discussion to bring you.
We have none other than Dr. Kim Williams. Dr. Williams is a cardiologist. He's a fellow and former president of the American College of Cardiology, and he's currently professor of medicine and chair of the University of Louisville Department of Medicine.
Honestly, Claire, I felt a bit starstruck actually, because Dr. Williams is the author and co-author of 41 articles in peer-reviewed research journals, not to mention the numerous review articles, editorials and abstracts and textbook chapters, and he's been honoured annually for the last 10 years as one of America's top doctors. So I'm going to admit I was actually really nervous for this interview.
Yeah, I was too. And he's also been guest editor and editorial board member for the Journal of the American College of Cardiology, Cardiology Today, and US Cardiology. So he has a wealth of experience in both clinical and academic cardiology. But he was so friendly, and we were doing this under time pressure. He'd been booked in for 30 minutes, first thing in the morning, but he did give us a bit more time.
Dr. Williams himself is a trailblazer in the field of lifestyle medicine. He's personally followed a plant-based diet since 2003, which resulted in him lowering his own cholesterol. So he definitely practices what he preaches.
He has a strong professional focus on the prevention of cardiovascular disease and addressing health inequalities, which as practicing GPs, we are also passionate about. So we were absolutely delighted to get a chance to ask him questions about his work, his background, and his thoughts on narrowing the gaps in health inequalities.
Yeah, and as Claire mentioned, we only had a short amount of time to speak to Dr. Williams, so we'll go straight to that now, but listen to the end to hear Claire and I reflecting as well as sharing our usual dinner recipes.
So this week, we're very lucky to be welcoming Dr. Kim Williams, a professor of cardiovascular medicine, to the Nutshell, with whom we're hoping to discuss at least some of the challenges in taking an equitable approach to improving cardiovascular health. Now, as a cardiologist who has been president of the American College of Cardiology, it's clear you have an impressive CV, and we will have a good go at summarising it in the show notes. But by way of introducing yourself, would you like to highlight your current interests and maybe a bit about how you got there?
Interesting that I got into preventive cardiology based on, and this happens, based on my own personal interests. I had been a very fit professional tennis player on a American Heart Association heart healthy diet that included chicken and fish, no red meat, certainly no processed meat. And so for anyone in the audience, if you think you had a good cholesterol in the past, check again. And so my LDL cholesterol, which on the US metrics, you kind of would like it to be less than 100. Mine was always 105, 110, back when that was not a bad number. Suddenly, when I turned mid 40s, it suddenly went up to 170. And so I was looking for solutions, and I knew a little bit about plant-based diet because I had read the work of Dean Ornish and plaque regression, and had one friend at Howard University here in the United States who was actually trying to push that diet for prevention. And interestingly enough, I went on a whole food plant-based diet. 6 weeks later, remeasured. My LDL cholesterol had been cut in half. So I was really impressed with it. And at the same time, this was 2003. So we had been doing statins for cardiovascular disease for a number of years, but it was really not quite practice for everyone all the time. And we didn't have the great numbers that we have these days in terms of risk calculators to help us discern who needs the statin and who doesn't. But I was seeing very much the same kind of response with statins that I was seeing with a plant-based diet if a person chose to go on it, or if a person chose to go on the statin. And so I realized that there are really two big preventive measures that one can do that both reduce inflammation and LDL cholesterol. Interestingly enough, since I started really focusing on this in my practice, I haven't had one person have a cardiac event if they're doing both of those things. So It's interesting. I know it's not exactly your question, but we see a number of plant-based doctors who were saying you don't need a statin, and a massive number of doctors prescribing statins who say nothing about nutrition. And I'm just here to let you know that 21 years of clinical experience and personal experience, I can tell you the best way to handle it, the elevated cholesterol and the risk that goes along with it, and the residual risk of inflammation, is to do both.
Absolutely. Great to hear that as a summarizing opening point. What we were asking ourselves was maybe looking at the fact that certainly in the UK, the costs of having a poor diet are completely decoupled from the personal cost of healthcare, because we have a state healthcare system. That's not the case in the US. So, why do you think the system isn't incentivizing people to look after themselves through something like a plant based diet to save money?
It really is a system that we have that has a lot of industry and a lot of industry interests. And for example, high fructose corn syrup. We know that the glycemic index of that is so high that it increases people's weight, increases the risk of diabetes. And yet, our government subsidies have historically increased the incentives to produce it by lowering the cost with government subsidies. The same is true for animal products. Same is true for refined grains. And you'll find some desserts on the shelves in the United States where this one very popular one, I won't throw a brand out there for you, but that has 14 different components, all of which are subsidized by the government, makes it incredibly inexpensive. And so that's a sort of a regressive tax on the health of the poor because it makes the unhealthy food more affordable. Now, September, I never will forget the day. September in 2022, the White House held a conference specifically on what we could do to try to undo what you've noted, and that is to try to get people more food security and less foodborne illness, which is apparently responsible for 80% of our healthcare expenditures in this country related to what we eat. And so there were great recommendations that many of us put in, and it was great to hear the President of the United States quoting the things that I had recommended, such as food labeling. It's been done in other countries, red, yellow, green. This one, the red would be red because processed meat, for example, is a World Health Organization Group 1 carcinogen, and it increases diabetes and increases stroke and heart failure. And whereas, whole grain, um, beans, grains, nuts, fruits, and vegetables and mushrooms will actually improve your health. And so label them differently. Now, let's educate. Let's do community education. Let's change our SNAP program. That's kind of like our food stamps for poor people who have food insecurity. They can get vouchers that they can take to the grocery store. Allow more food that's healthy than food that's unhealthy, for example. And so there are a lot of public facing education and programmatic things that we could, with great intention, try. Now, the sad part is that was September of 2022, and I haven't seen much of that, if any, really turn into legislation. And I'm hoping that this will continue, that all of the push to do these healthier approaches to eating and education will actually take hold in the United States, and we would save massive amounts of money. Now, how do you do that? And that's the fundamental of your question. How do you do that? Well, Finland did it. They incentivized fruits and vegetables over meat and dairy. And they had a dramatic drop in cholesterol levels in the country, and subsequently, with that, a dramatic drop in the amount of heart disease that they were facing. Wouldn't it be great if we could do the same thing?
Yeah. And I think, part of that question is that there is this observation that somehow keeping people sick keeps pharma and junk food companies in business. How far would you go in the idea that this is by design? How much does that form part of your view at the moment?
Yeah, never attribute malice, which is easily attributed to just regular business. That is, these are companies that were producing products. I mean, if you just go back to the 40s and 50s and, getting rid of starvation after the Depression and wars, and people thought that this was good nutrition. How long does it take before peer-reviewed literature saying that refined grains and sugar sweetened beverages and juicing, as opposed to smoothies, animal products of any variety, but some worse than others, eggs and processed meat being the two worst, according to the Harvard School of Public Health? How long does it take to change the way we behave? So no, I don't think it's a big plot. I think it's just money, and getting the companies that produce these things are just as powerful as the cigarette industry, and there are still people smoking. And I struggle with Europe because of that issue, and I don't know that there's much anti-smoking legislation and the regulation with packaged labels and the like, because I don't buy cigarettes at all. And you can tell me if you have those labels, but we've had them since 1964, and they've had a dramatic effect on the amount of smoking, so that it is less than Europe, but it's still there. Yeah, and it's a little bit worse here in Kentucky, which is actually a tobacco growing state, and our population suffers for it. So obesity and smoking together, diabetic smokers are the scariest thing in cardiology in terms of amputations, heart attack, stroke, renal failure, and death. So
Right.
it's just business.
Yeah. But we couldn't be clearer, could we, at the moment, on what sort of groups are losing out through the food environments they're living in, and through, the opportunities that they have in life to be more healthy. And we're finding that certain groups, when you look at trends, there are links between certain ethnic groups, between poverty. And when me and Daisy were talking before putting together some questions for the interview, we found we're so terrified of our biases. And you talk, for example, about the study on the loss of diagnostic reasoning that we have for unstable angina, where we're looking at the race and gender of a patient as clinicians. Can you describe that study here, and any ideas on how clinicians can start to address the biases they may have?
So it's obviously a very large topic. Having worked primarily in Chicago, then Atlanta, then Detroit, but most of the time in Chicago before this job, I'm used to actually a lot of racial segregation. Detroit, because it changed to a poorer African American city essentially. Chicago was just incredibly segregated. Not as much in terms of racism and unfairness, just segregation. People live with their own kind, and the same was true in Atlanta. Louisville is not like that at all. And I'm sort of waking up late in my career and realizing it's not just about race, it's about poverty. The economic differences in Louisville and Chicago and Detroit and Atlanta are huge. And it's just that, the poor neighborhoods that I actually work in on the west end of Louisville, they're interracial. They're all friends. It's not, it's something I didn't see in the other cities. What is it that we really need to do about the economic disparities and racial disparities that are driving heart disease? It's really basically education. And the education is on both ends. It's not just the patients, it's the physicians as well. When we do surveys of nutrition information in physicians, they really haven't been taught very much. And when we do surveys of their own eating habits, it's a publication that I came out from our institution last October at two universities where you're supposed to like read guidelines because you're at a university and teach. And what we found is that there was one person eating the optimum diet out of the entire 274 people. And so we lack education, and then we lack practice and the tools to try to get this done. So until we fix that, and your question about ethnic disparities is right on, because there are historical issues. Growing up on the south side of Chicago, the food that we were eating, so-called soul food, is essentially derived from slavery, where the things that the big house didn't want to eat and they were throwing away, that was what the slaves learned to try to survive on. And it is food that you can survive and, live to you're 45 or 50 years old. It's not something for longevity. It's not something that will lower the gap in life expectancy between our races. But again, I just want to emphasize, because it's so acute with my job every day, the Appalachian white population has the same risk as our African American inner city, and similar diet, similar access to care issues, similar education issues, and cardiovascular disease runs rampant.
So, I mean, can we just clarify that point? Because we've certainly got different guidelines, for example, on the weight that somebody should be in the UK, where you say that the ideal BMI is between 18.5 and 25. But if you're Black or Asian, you're looking at probably the lower end of that range, or you've got an increased risk of getting diabetes. So, but you've described the diet differences that might generally be there. Is any of the increased cardiovascular risk faced by, say, Black people in the US, is any of it based on genes?
So very little. So a couple of genes, if you include amyloid heart disease, there is a not infrequent mutation that leads to amyloid infiltrative cardiomyopathy. But it's in typically older men, African American men, typically with a history of high blood pressure and perhaps some chronic kidney disease that tends to bring that out. But it is a mutation. The other one that's important is a couple that I would mention. One is the genetic proclivity to have higher LP little a levels. And this is a risk factor that not everybody has been paying attention to. Now we're going to be paying attention to. Why? Going back to our earlier conversation, because pharma has some solutions now. There's 2 phase 1 and 2 phase 3 drugs, meaning that they're going through stages of approval with the Food and Drug Administration, collecting research showing that they are able to dramatically lower LP little a. Now, what you have to do with that is follow those people out for 5 or 10 years and find out if it's lowering the LP little a, which we know is associated with heart disease risk, is it actually lowering it change things? Because we found out the hard way with HDL cholesterol. We're so happy to have all those drugs to raise HDL cholesterol. Not one of them actually did anything. But if anything, there was a slight increase in mortality. We're sort of at the beginning of it, but the African American population has genetically more LP little a than other races in the United States. The other one is kind of indirect, but so important. It's called the ApoL1 gene, and that codes for more chronic kidney disease. And so you could have, a Black, a white person, and a Hispanic person, all with blood pressure running 140/90, and the kidney function starts to worsen in the African American a little faster than the other races. Some of that has to do with so-called nocturnal hypertension. There are races that have racist consequences in their lives, and the stress of having that ends up coding for more nocturnal hypertension. And I wish I could get every practitioner to understand that the nighttime blood pressure is important. And it isn't, that one isn't really genetic. It may be dietary. It's likely social, because it's been shown in the United States that urban Blacks have nocturnal hypertension, rural Blacks have it. In Africa, urban Blacks have it, and rural Blacks do not. And so it's something about society, something about our system that makes this happen. And just throwing in a little bit of a tangent here, please, if you're looking at African American people, and this does apply to Blacks in Europe as well, make sure that you're using the long half-life drugs, because I see people using drugs that have a 2 or 6 hour half-life, and then those people are uncovered at night. So anyway, getting back to that ApoL1 gene, for whatever the contributors are, and a lot of it is diet, you end up with more kidney failure. So we are 12% of the population in the United States and 35% of the dialysis patients. And there's about 12 different mechanisms by which kidney disease promotes heart disease and heart failure, and accelerated atherosclerosis, poor vascular repair. So it really is a blight on the cardiovascular system. Unless you're not availing people dialysis, the kidney disease patients don't die of kidney disease, they die of heart disease. And so Uh, so these are the genes that we know of. I know people talk about the proclivity to have hypertension having to do with slave boats being stuffed in the hull, and the only people who survived were those who were genetically selected to conserve sodium. That's been argued for so many decades back and forth. The bottom line is probably none of us should be eating a lot of a high sodium diet, but I do find that our African American population is extremely sensitive. We drop to our American Heart Association recommendation of 1,800 milligrams of sodium in the diet daily, and the blood pressure will come down. But that's true because we're doing that with plant-based diet. The last part of that, since I mentioned the kidney disease, I'd love everyone who's in the sound of my voice to recognize is the effect of animal protein on kidney disease, which then gets the heart disease going, as I mentioned. If for some reason it seems to be little known, even though it's throughout the literature, they could just put in their search engine animal protein chronic kidney disease, and they'll see this massive amount of literature come up, including recommendations from our National Kidney Foundation, not from some rogue vegan journal like the one that I edit. Okay, so to the National Kidney Foundation saying, please put all your kidney disease patients on a plant-based diet, and it makes a turnaround and stop the progression to dialysis. So it's really important to dissect out all of the things that lead to our coronary heart disease. And if we attack them one at a time, and then ultimately all together, we can do this. So the last thing you said, you mentioned about weight. So weight is a major issue, but it really is about central obesity. That's where the metabolic syndrome is coming from. And so we have people who are overweight or obese, but not particularly picking out the belly. And then we have the reverse, thin people with a big belly, and they are at higher risk, higher insulin levels. Insulin is a wonderful hormone. It's atherogenic. So it's the more insulin you have, the more heart disease you're going to have.
Okay, so I think in summary then, we need to be looking much more at social and cultural factors driving cardiovascular disease than we do genes at the moment.
I pulled out some. They are obscure, but they're important. It's just that if we fix the diet, we fix all of that.
So can I focus in on that a little bit for the audience? If we are looking more at lifestyle as a means of preventing or reducing the risk of chronic disease, what would be your priority areas that people should either as healthcare professionals educate their patients on, or as you say, as healthcare professionals ourselves, focus on within our lifestyles?
So you're delving into a good area there. Does everybody need to do a whole food plant-based diet? Is there room for sort of a cheat day or including fish? Oh, of course, that was before the microplastic publication in the New England Journal of Medicine. If you hadn't heard about it, I just should mention it, that we have polluted our oceans to the point that the seafood has higher collections. I mean, there's plastic everywhere. It's in bottled water, it's in plants even, but the highest concentration that people can ingest seems to be in seafood now. And it seems to be unavoidable, other than just don't have it in your diet. Interestingly enough, there was only one Harvard study that suggested that, okay, red meat is the enemy. Red meat increases heart attack, stroke, death, cancer. No good for you. What can you substitute for red meat for protein and decrease your mortality? And the answer was pretty much everything. That study showed that soy protein was the numerically the best, but pretty much any vegetable protein. The fish in that particular study had a 6% increase in mortality over red meat. And everybody's going like, how could that possibly be? I think it's either a statistical quirk or it's plastics. So we have to sort of modify our diet as things. So I was going to tell you that, again, that processed red meat is the most dangerous thing that people will do. I'm not so sure anymore. But so we could approach your question from two different ends. One would be, could you cheat with a little bit of this or a little bit of that every now and then? And that actually may be true, but for those who are risk, like me, that cholesterol gene, whatever I have, African American, male, over 60, I wouldn't cheat at all because I know that I am the substrate for high risk. And then there are other people, that whole PCSK9 deficient thing that started all those drugs, where they found that people have an LDL cholesterol of 14. They're probably cardiac immortal, and they could eat whatever they want. And, we're all going to pass away, but it's not going to be atherosclerosis for them, more than likely. So we may be able to adjust the diet based on the risk, but that's ignoring the two big elephants in the room, which are animal rights and planetary sustainability. If you just consider those, everyone should be doing a whole food plant-based diet. And, with all due respect to my vegan colleagues who eat the vegan ice cream and the vegan beignets and red velvet cupcakes, a lot of vegan food has become very popular, but it's not healthy. And there is another Harvard study that actually looked at unhealthy plant-based foods and saw that the increase in cardiac disease was just a touch higher than eating animals. Unbelievable. So I kind of tease my friends that all the vegan stuff, the good for the planet, because there's no greenhouse gases and it gets rid of humans. So, but
Now, I mean, on this podcast, we definitely advocate for whole food, plant-based as much as
I was
possible.
so
But
glad to hear it.
absolutely. In terms of progress amongst cardiologists since you were president of the American College of Cardiology in 2015, have things changed? Have you noticed your colleagues sort of following a lead?
So interestingly enough, we just left the American Medical Association, where the ACC, the American College of Cardiology, has delegates to try to affect healthcare policy, and the food has always been an issue. One of the major drivers of trying to change it is Neil Barnard, who I'm sure you've heard of, PCRM, and he is one of the delegates for the Washington D.C. EMA, and we all were getting together and commiserating, and then we just started chipping away at it. And I can tell you that the Cardiovascular Section Council had healthy food at the AMA. I actually have, maybe I shouldn't do this or admit that I do it, but I actually take pictures of all the food at medical meetings, and I'll put them in my talks. And, to have, major societies who are supposedly or who are focused, they're not supposedly, are focused and dedicated on preventive cardiology, serving eggs and bacon and sausage. This means that there's a disconnect between the data and the understanding of physicians. It's affecting them personally and professionally, because you're not helping your family, you're not helping your patients. And the leading cause of death of physicians, including cardiologists, is still heart disease. Kind of ironic.
Yeah, absolutely. There's a lot of work to be done still, isn't there? If we have some more of your time, we were just really interested to know your experience of using health screening as a way to improve cardiovascular health, particularly in harder to reach individuals.
Yes, this is actually what we do in Louisville. Started it in Detroit. It was actually the Association of Black Cardiologists that sort of first started doing the so-called Spirit of the Heart, going to churches and doing diabetes and high blood pressure screening. We've refined it a little bit. We were doing, with the help of Dr. Iris Taylor, she was president of the Detroit Receiving Hospital. It's a really critically important catchment hospital in down Midtown Detroit. And she decided that everyone who came to the emergency room was going to get diabetes screening with a finger stick. And it costs money, but it saved lives, to get people to know and understand. So I took that lead, and we started in cardiology while I was there, doing events out in the public. And we would try to advertise them on television. People would come because they didn't really have good access to care. And they knew, they'd seen a doctor a few years ago, their blood sugar was bad, they never did anything about it. So people would come in droves. And so I realized that expecting the patients to identify their illness or wait until they're sick and then come to us really doesn't work as well as the early access that we could do if we just do public screening. So when I went back to Rush, the same month that I took that job is when the ASCVD risk calculator, that's atherosclerotic cardiovascular disease, it's still online. Anyone can download it. There's an app for it. And you put your ethnicity, gender, age, blood pressure, and your cholesterol elements in there, and whether or not you're a diabetic or a smoker. and it will tell you your 10-year risk of heart attack, stroke, or death. That really made us take off. We started going to areas on the west side and the south side of Chicago, created, and if you're going to do a big program, you have to have a nice acronym. Mine was helping everyone address risk today, okay, which spells heart, of course. And so the heart program actually screened hundreds of people. And you find about 80% of people have some significant abnormality that if you weren't doing this, it was going to ravage them at some point. And so I believe that screening is a big, important thing. I pushed for that when I took the job at Louisville. We go to the West End, we go to block parties and churches, and Juneteenth is happening this weekend. Juneteenth is, and for the British audience, there was this tiny little bit of American history after the Civil War and the Emancipation Proclamation, where blacks were freed. There was an area, there were probably more than one area, but famously there was an area in Texas where blacks did not know for a couple years that they were actually free. And then when they finally found out, that was on June 19th. This would have been 1867. And so, as it turns out, that is now a national celebration called Juneteenth. And so that usually in African American neighborhoods, there'll be parties. So we're there. We're setting up a little booth, doing the blood pressure, doing the finger stick. What we're trying to add, and this Juneteenth will be the first time we've actually added it, it's the assessment of kidney disease, because about 6 months ago, the American Heart Association came out with a new calculator after 11 years. It's called a Prevent calculator. Anyone can go online and look at it. And they did something it's not going to help the British audience, but maybe knowing the British Cardiovascular Society, who are just wonderful people. I miss going to Manchester and speaking with and for them. But it would be good to have a calculator. You wouldn't do it as much by race as I understand UK. You'd have to do it by area, okay? Because Irish and Welsh and Scottish and English are all very different, particularly with the rates of high cholesterol, which you guys have solved, by the way, by testing all the kids. You find the familial hyperlipidemia in an infant, and then you go back and get the parents, and then you can get the grandparents too. You're gonna wipe out. Okay, that's public screening. That is the power of screening. You could actually wipe out familial hyperlipidemia, at least the unknown effects of it. So the Prevent calculator added kidney function, and it removed race, and it added social determinants of health based on your zip code, where you live. And so we're looking forward to using that one. We had to buy new machines and we're working out the kinks, but hopefully we will do a more refined public assessment. And yeah, we're going to keep going into churches. We've done, big groups, hundreds of people. There's a company that does so-called African American male wellness walks in pretty much every big city. And when they came to Louisville, there we were. We must have screened 300 people because they threw us a curveball on the last day. I know that's an American aphorism, but pulled a switch on us and said, well, it's an African American male wellness, but we're going to invite women, which really tremendously improved the population because the women bring the men. The women, they feed the men. It's like we're helpless without women in this community. My goal is to get 10,000 people done before I'm done. Again, we get that very consistent 80% abnormal rate, and some of them are really critical, and we can get them in to be
That's so
tested.
inspiring. It's really inspiring. Thank you. We could ask you questions all day, but very aware of your time constraints. So could I ask you one quick last question? Because our listeners love to hear what our guests are eating. It gives them some inspiration for plant-based nutrition. So if you can tell us what you had for dinner last night or you might be having for dinner tonight.
So interestingly enough, I'm finishing up a project. There is an app. I don't name brand names on podcasts, but there is an app that you may have seen where it'll detect the location of your phone and tell you where the plant-based restaurants near you. I've been doing this for years. What I'm getting at is we're now up to 400, I think 35 restaurants around the world I've probably got 12 in London from going to Wimbledon. And that app works pretty much everywhere. Riyadh, Saudi Arabia, and Pareda, Colombia, Alexandria, Egypt. Those are the three where it's struck out. But pretty much everywhere else I go, I would, see what's around me. So that evaluation means that I actually go and get the food. So again, I won't say which brand, but I'm actually in San Diego picking up my granddaughter to take her across the country. Loads of fun. And I went to one of those places near the San Diego airport. And, I'm just going to be honest with you. The vegan chili had such a high sodium content, but I'm sure that makes it popular and sell. The chicken burger, which is, plant-based chicken, had a refined grain bun, and so when you're out and around, you're essentially inundated with unhealthy plant-based food if you're a plant-based person. So what I ate last night probably wasn't all that good. I did limit it because I just have a low tolerance psychologically for unhealthy food. But all I can do is try to finish this manuscript and get it out there, and hopefully everyone will change. Now, I have to say, I have to defend them a little bit. Over the years, the more healthy the restaurant, the shorter its longevity.
Yeah. Yeah. That's
So
across the board, isn't it? Not just
yeah,
plant-based. Yeah.
we've got to
Yeah.
start with education. And if
Perhaps we
there's
should have asked you, Dr. Williams, what is your ideal home food, or what you make at home that you like?
a whole food plant-based diet, several, go to, I wouldn't have, if it's beans, grains, nuts, seeds, fruits, vegetables, and mushrooms in large quantities, and because I play so much tennis, so it's hard to pick out from those what I eat more of. I probably end up with more salads on the run than anything else, but all of the above.
Big bowls mixed full of everything. Yeah. Very nice.
Indeed.
Very nice. So thank you so much for your time. It's really been an honor to have you on the podcast today. We really appreciate it.
Thank you so much for having me.
Welcome back, listeners. I hope you enjoyed that interview with Dr. Williams. Daisy, what was your main learning from that?
Oh, so much. I mean, it was such a rich discussion with so many learning points for me. And I really enjoyed listening back to it a few times, as I felt like I learned something new each time. And before the interview, I didn't think I'd be learning nuggets on African American history.
Do you mean when we learned about the significance of the Juneteenth celebrations?
Yeah, absolutely. I love that. And I also had to look up what Dr. Williams was referring to when he mentioned the UK leading on familial hypercholesterolemia screening in children in order to identify adults, because I wasn't aware of where this is happening.
No, we weren't. Where were we? So what did you find about that?
So I found a pilot called the Child Parent Screening Service, the CPSF, where children aged 1 to 2 are being tested whilst receiving their childhood immunisation. So it's done at the same appointment, and it's done via a heel prick test. And if the child's cholesterol is raised, the sample will be sent for genetic testing. And identifying children with the gene, they can then be offered dietary advice really early on in life. And parents then identified with the gene can be offered a statin. So it looks like a small pilot still, due to complete in October this year, after which there will be a need for an evaluation. So I think we're still a way off from seeing this being rolled out everywhere, but nevertheless.
So we'll watch that space.
Yeah.
In case listeners are interested in the other issues around inequalities in healthcare and races in particular, we wanted to mention a couple of things that we looked at before we spoke to Dr. Williams, one of which was the book Divided by Annabelle Soamimo. It was an excellent resource. And also, I recommend everybody watch the documentary They're Trying to Kill Us. It's nearly a couple of hours long, but it's free to watch on YouTube, so you don't need to watch it all in one go.
Yeah, brilliant. A few resources there that we recommend. And lastly, as we always do with our episodes, given the time constraints, we didn't have our usual dinner chat with Dr. Williams. So Claire, will you tell us what you're having for dinner tonight?
So I'm actually going to tell you what I had for dinner last night, if that's okay.
That's okay.
So I caught sight of a recipe popped up on Facebook, which was for Chinese dumplings, I suppose. And I mean, sometimes they're called gyoza, aren't they, if they're Japanese? But anyway, based on the same principle, you make a sort of crumbled tofu filling, chop up some cabbage. I use some Savoy cabbage, which I think there's plenty of it about at the moment. And then add some spring onions and a lot of chili, put in some garlic, add some soy sauce and some ginger, and do like a sort of dumpling filling. And then you make a dough. And I've done this before with rice flour, but this recipe was just using normal plain flour and salt. You add some warm water, and the key is to knead that dough long enough that it becomes quite bouncy smooth. And then you take walnut-sized pieces, roll them out into a disc, and pinch them together. If you've got one of those bamboo steamers, great. I haven't. I just use my normal vegetable steamer, put in a piece of greaseproof paper and stuck the dumplings on there. And then just because I wasn't confident that my steaming had really done the job in cooking them, I did actually pop them into the pan and dry fried them a bit just to brown them off. And then ate those with a nice rice wine vinegar, soy sauce and sesame oil and a bit of chili sauce, kind of made a dipping sauce there. They were really good.
They looked really good because you sent me a photo.
I did. I was so desperate to get back in the kitchen, having been on the road for a couple of weeks. There was so much filling left from the dumplings that I just added some more Savoy cabbage to that, dry fried that again, and I kind of used that instead of having a rice dish.
Oh, very nice. That sounds excellent, Claire.
But I want to emphasize how quick it was, because you kind of steer away from those recipes quite often, and you go to the freezer because you can get really good frozen dumplings, but they're really not that difficult to make, and you can pop together some really interesting fillings.
I think the fillings I'd be happy to make, but it's the actual dumpling, itself that do they come? Could you buy ready made, or is that not?
Do you know, I think you can absolutely buy those discs, can't you, in certain supermarkets? They're little discs for making dumplings.
But you found it quite easy to make yourself with the...
Yeah, I probably made them about 4 years ago and then not come back to it since, for whatever reason. As I've said, I'm a bit of a fair weather cook with certain things. I'll make something a lot and then I just move on from it. But no, you can use rice flour and water, or you can use plain flour and water. And the key is, and I remember this from last time, to really knead the dough, give it 5-10 minutes of kneading until it feels really soft and smooth and is quite sort of bouncy and stretchy. And only then can you roll it out into that log and chop it into those walnut pieces to make the discs.
I think I've got a mental block with dough. I'm going to have to overcome that. I'll have to try it. Try and make my own.
Yeah, I really push it. So if you're not making your own dumplings, what are you having for dinner tonight?
Well, I'm not going to give you a recipe this time, but I'm going to give a suggestion, a tip, because we talked ages and ages ago, if people have been listening to us from the beginning, about quinoa. Do you remember that conversation we had about the benefits of quinoa? And you said, I'm not really one to make it, but I'll eat it if I'm in a cafe and it's part of a bowl or a poke bowl or something. And I thought, yeah, that's right. So I've purposely, over the last few months, been trying to make my own quinoa.
Daisy, can I just interrupt you? I almost feel like we should say to listeners here, and for those wondering, quinoa.
Oh, is that how you pronounce it?
No, you do pronounce it quinoa, but I'm always afraid that people won't know what we're talking about because it's written so differently, isn't it?
Quinoa, yeah. So it's a grain, isn't it?
Yeah, and it's gluten-free. Yeah.
So anyway, it hasn't always been very successful, my attempts at making it. Sometimes it's just been a bit too watery. So I read somewhere that you could put it in a rice cooker. And I do have a rice cooker, and I like using it a lot. And I did exactly the same proportions as I would cook rice with the water and the quinoa, and it came out perfect, Claire. Absolutely perfect. And now, instead of rice, I'm eating a lot more quinoa. because I can just put it in the rice cooker, switch it on, and it's done, 20 minutes later or whatever. So it's my tip rather than a recipe today, because I feel like it's revolutionized my whole grain eating habits.
Absolutely. And that's where you've got to turn into that person where you open the fridge and you've got different tubs where you kind of make yourself a salad bowl and you just take a scoop of your pre-cooked quinoa and some of your edamame beans from the freezer, and there you go.
Well, it came really about just trying to move away from white rice, because that's been a staple from like my childhood and being brought up on it. And I feel like quinoa in a rice cooker, I'm very, very happy with replacing maybe not all the white rice I ever eat, but some meals. So give it a try, listeners.
Brilliant.
Great. Well, that's it for today. We'll be back next week with a mini episode, after which we are taking a short summer break. So you'll have August off to catch up on episodes that you may not have got round to listening yet.
Indeed. I hope you don't miss us too much next month, but we'll be working hard behind the scenes, getting things ready for season 3. And we've already got some really exciting episodes lined up for you in September. So we look forward to bringing you that new season very soon.
Enjoy the nugget next week, everyone. Have a lovely summer and see you in September.
Thank you for listening to the podcast. We aim to bring you the most up-to-date evidence-based information about the benefits of a plant-based diet, and we'll add all the links for further reading in the show notes. Please remember that everything discussed on here does not constitute individual medical advice, so please consult your healthcare provider if you have any medical concerns.
In the meantime, please subscribe to the In a Nutshell podcast on your usual streaming service and download our future podcast for free. And since food can be the best medicine, don't forget to share us with all your colleagues, friends and family. Until next time.